Right. So we have these cases. Got it. Yeah, it's cool. All right. So there's a patient with pancreatic cystic lesion on the scan in head of pancreas. So let's see. So as I explained, I think it's partly recorded as well. So what you're looking at is obviously we're discussing. This is the lesion in the head of pancreas, and this is the cystic lesion. This is the pancreatic parenchyma. What you can additionally try and do is, let's see, we can do ES elastography. It gives you an idea about the consistency of the lesion. All right. So it's a little heterogeneous. Red means soft. This is firm and this is hard. Okay. So that's got a mixture of components. But I think this is more cystic lesion. So I don't think this is taking up color. Now this is technically hard, but again, I'm not a big believer of elastography. But anyway, it's a heterogeneous lesion. And it's got what we call as microcystic lesion. So you see these are small cystic lesion spaces. Guys, biopsy? Yeah. So these are microcystic lesions with septations right there. So this is actually a very, very classic appearance of a serous cystic neoplasm. All right. So this is the largest cystic component in that whole thing is this one. So yeah, so it's a very small cystic component. Yeah. All right. So what we want to do is, when you're doing a biopsy, you want to position the needle in the lesion in a manner where it's on the left of your screen, so that when the needle comes out, it's going to hit the lesion straight and obviously an avascular path. Correct. Yeah, it's an Olympus. The blue dot, which is on the right of the screen, right? So that's where the blue dot is, and then we are going to go from there and get the thing. All right, perfect. All right. So honestly, I've not been a big fan of using the elevator, but you can see with the use of elevator, now the needle path. Why do you move this? So the needle path is sort of here, right? So it's going towards the edge. I'd like it to come more over here. So the needle path has to come more here. Okay. All right, okay. So let's first get the Doppler, see where things are. Obviously you want to avoid that vessel. There's something in the wall of the duodenum which is pulsatile, but I think we are okay with that part there.
And what type of needle do you like to use?
Yeah, so I'm using Aquarius. I like this one. Okay. Aquarius is a good one. And it's got a very sharp stylet. So you normally, when we put a needle, you get the stylet out. In this needle, you don't put the stylet out, you push it in. So the stylet is very sharp. Okay, so that, and I'm going to use elevator a little bit, try to get in the middle of the lesion. Yeah, okay, now we are here. So the technique is to just gentle, firm push, but a very controlled manner. I don't use the lock, but you can always use the lock if you need to. All right, so now. For beginners, maybe. Yeah, for beginners, yes. When you guys will start learning on this, you will see. All right, so there you go. That's the needle tip. Now it's at the edge of the lesion. So the first thing you do is pull it up gradually.
Slow pull.
Slow pull it up, and then you want to be in the proximal part of the lesion, right? So there you go. So now in the proximal part of the lesion. And then I'm going to go in, and it's going through some septations, so it leads to some sort of so you have to do these jabs. Now I also hit a vessel, I think. You see, so there's a little bit of bleeding that's taken place, but that's okay. I mean, that much is fine because the vessel below there. Now the challenge is you push and then there is firmness, and then you push against it and then there is a give way.
Okay.
So that's what's going on at the cystic lesion there. Okay, now you see I'm pushing, nothing's happening, right? So what you need to do is do a jab like this, like a little jab.
To have a good pathology result, do you like to do like 2 times the biopsy or 3 times? I heard that.
Oh, how many times?
Yeah.
So it's the way we do it now is with a macroscopic evaluation, which is what we term as MOSE, M-O-S-E.
Yes.
whereas Rose has given way for Mohs now, where you just visualize how it looks and then take a call. Now, in my experience, couple of passes is usually good enough now with these lovely needles and right techniques. It kind of depends on the lesion, you know. Now, this is a small lesion and the movement is limited. So, okay, we're good.
So maybe just one time with a good fanning and it's okay.
Yes,
You have
yes.
white tissue.
Histopath, no cyto. Yeah, now the thing is, obviously, in India, you have to keep using them again. So that's why the yield is less. You have to use sometimes more. In fact, I hit a vessel, I think. So there's a little bit of a blood clot here. See there? So this is a blood clot here.
Okay.
Well, as long as it's contained, I think it's okay. There was a bit of a, which wasn't taking Doppler. But anyway, we'll just want to make sure you monitor him for a while. Some oozing. It tends to be a vascular lesion and there is a little bit of a clot. It's okay, that much we can live with. Usually don't encounter, but I suppose it's a small lesion, there's limited room for moving, bunch of vessels around. It's fine. I would just observe it. I don't expect it to increase.
Yeah.
Probably a little bit of venous blood and it'll stop.
It was controlled, so...
yeah, it's controlled, so it's fine. Yeah. Very rarely, now I've been 10 years I've been doing FNBs. Yeah. I've had one time when a patient had to go to IR for embolization and that patient was on day 5 of Plavix.
Okay.
Unfortunately, not much of a Mohs can be done here because of the hemorrhagic sample. Show me. Yeah, so not much of a Mohs can be done, but okay. Let's make sure. Can't see. Yeah, there is stuff. Yeah, it's very hard to tell. It's fine. We'll do one more pass and then we'll leave him alone. Especially with these vessels and bleeding, I'm not going to do more than one more pass. That's pretty much it. It's getting a little more difficult now because of the blood clot.
Yeah.
And the position now, it's pretty deep right there. Okay, never mind. All right.
Do you have any tips, like for beginners, how to perform FNB? Like always stay steady, have your needle always in the screen. Some tips like this.
Yeah, well, so the first thing, obviously, you want to make sure you're getting an avascular path, a steady position. You know, your needle has to be visualized while you're doing it. No blind movements. Yeah. Now, here's a challenge. Now, I can't really go here because it's the head and the lesion is at 4 or 5 o'clock. Before, when we started, you see, it was a very nice position where we actually were, you know, getting the thing on the left of the screen. Let's see if I can manage to do that again with this lesion. Okay. All right, let's go to D2. Let's see if we can find an access from there. Yeah, so I think, you know, as we do more cases, I'll see case to case, I'll be giving particular tips on how to do it.
Do you use sometimes the Sonoview in India to enhance the...
Yeah, good idea. Good question. In fact, we've not been using it in our unit much. We've seen a little bit of a limited use and cost is a factor.
Okay.
But I think we should try to do it in sometimes probably NET or some such cases where it can be of benefit. Yeah, okay. Dry gauze, please, yeah. यार AC था कम है क्या बोलना उसको AC करने को it's hot here yeah alright so let's go back now okay now I'm not liking the positioning it's not good see, it's getting more difficult to get in there okay that's somehow the thing is really changed in position okay let's see, remove this. What I'm going to do is remove the scope, try to get a better position and then get the needle in. Sometimes that works better. I think that little bit of that blood clot is now caused. Yeah, okay, that's the perfect position, but it's as good as it gets. I can't get better than this. Yeah,
so
that's it.
You push a little bit to have the lesion.
Yeah, I think in the bulb, what I'm trying to do is trying to push and pull and get the scope and scope hold. Yeah, that's it. So this is as good as it gets. I'm not going to get better than this. And I have to avoid this vessel, which is probably wasn't very visible then, which I may have hit. And there's something in the wall.
Yeah.
And then there's one. So we have to find a way. The wall I won't bother, but this one we should avoid.
The big one, the bigger.
Yeah, yeah. And it's right in our path. Right. So let's see. Try to do something. Okay, now needle, please. It's a small lesion, so getting access to it is also another challenge.
And you say at the beginning that you didn't like to use the erector. Why? Do you prefer?
Yeah, because the movement of because the pressure that you're going to put with an elevator can become more difficult to judge.
Okay.
And that's why I don't like to use elevator. If I can avoid it, I prefer to avoid it. Because with a straight scope without, not straight scope, but without use of elevator, I know how much pressure is going to move the needle, how much.
Okay.
But when it comes, this is bad, obviously. It's a vascular lesion. You can see a bunch of vessels here. I don't want to hit that. Trying to see if I can find a middle axis, but it's not very fun here. Okay, let's see if I can. All right. Am I through? I'm close to it. Near it.
Yeah, I think.
Yeah, I think so. The idea is to be between those vessels. So I believe I have been very close to the pulsatile one.
In between the two.
Yeah, I think.
And inside the.
Okay. Yeah. Please. Yeah. Okay. Don't experiment. Come on. Not now. Next case. You see how much space I have, how difficult it is to get in. Alright. Alright, okay. The other thing we could do is get a little, in smaller lesions, what I like to do is a negative wet suction. Because negative wet suction is beneficial in these, because you have a constant negative suction, lead to a bloody sample, but there is a constant negative suction, which you don't get with,
That's the question that
the slow pull is a good one, less bloody sample, but then that can be a real problem.
All right. Like those cases where you have like semi-cyst and semi-solid mass. The question I was about to ask, when you use the syringe to have a negative pressure and also have some sample to send to the cytologist?
Yeah, I didn't want to bother with the cytology because there's a limited sample.
Okay.
And we'll get them histopaths to be able to characterize a serous cystic neoplasm based on the appearance on the histopath. Because you're not looking at malignancy, therefore cytology for me is of no use.
Yeah.
I don't think they'll be able to diagnose SCN based on a cytology, right? So they'll need more histopath. So if you have two limited passes, only two passes with all these blood vessels, I would focus more on getting the tissue for histopath so that they can actually make, a better judgment of this. Yeah. So that was the idea behind not doing it. Yes, what I could have done slightly differently is to give negative wet suction. So if you don't have an assistant, it's probably a good idea to get negative wet suction, which is negative 20 cc with a NS filled saline syringe.
In some centers, they told me that it depends on who they trust, the cytologist or the pathologist. So
I see. Yeah, we have the same. Both are the same. So it doesn't matter. They do it here, but not in this case. I won't bother.
Yeah.
I'll ask her to do a proper eval. So you could see there was a bit of a flow initially post biopsy. Right there was all the flow over there. This is the flow in the surrounding area. It's not uncommon for them to have multiple vessels around. It's a vascular lesion, but these are arterial structures around there. Anyway, I think it's fine. Now it's settling, not much blood. And I'm going to stop here in view of hematoma that's formed right there. Yeah. All right, it's self-limited, so I wouldn't be too concerned about it. But all right, so you guys want to see, both of you, since they've been around for a bit. Come, take a look. Only the bulb, yeah. Go ahead. All right, so, yeah. So you want to go in the bulb. Now press this button. Yes. Pull back, yes. Next case konta hai? अच्छा यहीं पे कर लेते कितना है का it's okay ooze don't worry what happens when there's a biopsy with endoscopy and there's blood do you put like a hemo spray on that it's okay there'll be some blood I know I'm just kidding I know I agree I'm just kidding the point I'm trying to make is you do biopsy, there is blood, there's a little bit of blood that flows, it stops. Same thing with the EUS. There's a bit of blood, it'll stop. But obviously, if it's pulsatile and spurter and like the whole screen is red, it'd still be okay for the most part, but yeah. Go, push, go. Alright, where are you in the antrum? I'd say first week for you, don't worry about that. Just do a basic exam of the stomach. No, it's okay. You got it. Just the basic exam of the stomach. Transgastric assessment of the structures. Alright? Pull back here. Okay, I'm feeling really stupid now. I should have seen from here. Much better. Look at that. This happens sometimes, right? Oh yeah, 100% from here, yeah. A bit of a distance, but no, maybe no vessels. And initially it was good, but the second pass I could have done from here. But still, it can be hard from transgastric to get access. Same lesion. All right, there you go. So you get the